All right. Good morning or good afternoon, everyone. I am Rachel. John and I had a little technical difficulty, so we apologize for the late start, but I shouldn't keep you the entire session, so we should get out of here early. So my name is Rachel. I'm one of the pharmacists here. If anyone can't hear me now, please let me know, because I do have the headset on, so you should be able to. And as I do this, if you guys have questions that you want to discuss, feel free to throw them in the chat box. If you don't want to kind of ask them in front of everyone, my email is up on the screen. Feel free to email me afterwards with any questions that you have during this or that you might think of afterwards. The other thing is that I obviously am teaching about diabetes today, but if you guys have any questions about any of your medications, access to medications, co-pays, things like that, feel free to forward them to me. I am usually pretty accessible on my email account. All right, so we will go ahead and get started. So I know you guys have gone over a lot of this, but we'll briefly talk about what actually happens in diabetes. So today we're mainly going to focus on the treatment of type 2 diabetes, but just for completeness sake, so type 1 diabetes is usually an autoimmune disease. It's not very well understood, unfortunately, still in terms of pathophysiology. Tends to happen more often in children and adolescents, usually less than the age of 30 years old. But essentially what happens in this disease is that the pancreas just does not produce enough insulin for whatever reason. However, today, like I said, we will focus on type 2 diabetes, which is often caused by a bunch of different things that kind of come into play together. So we know that type 2 diabetes ultimately is caused by high levels of glucose circulating within the bloodstream. Because of this, our pancreas can essentially get burnt out and start to produce less insulin over time. The cells of the body, such as like our muscles and our organs, also become less responsive to insulin because they just get kind of tired of hearing that noise from the insulin and the glucose. And then, of course, our liver also produces extra glucose, which is just something that happens naturally. So it's usually a combination of kind of these four factors coming into play that cause the development of type 2 diabetes. So how to manage diabetes? I know that John has probably gone over all of these things. So diet is a big one. We always say low carbohydrates, high fiber, of course, exercise, regular exercise for 30 to 40 minutes a day. And then what I will talk about today are the medications. So type 1 diabetes is mainly and only treated with insulin. It can become a little complicated. So just for completeness sake, we'll talk about insulin, but we're not going to get into the nuances of it because it can sometimes be just a lot of info for people. But if you do have any questions about insulin regimens or things like that, feel free to email me. However, for type 2 diabetes, we have a bunch of different options. We can use oral medications, we can use insulin, or we can even use some of the other injectables. And this kind of used to be something that when I taught this class, we mainly just talked about the oral meds, but it seems like more and more we are going to talk about the other injectable diabetes medications. And our goal for most of our diabetic patients is to get an A1C around 7%. That's also going to be a little bit variable depending on the patient, other disease states, risk of hypoglycemia, stuff like that. But for most patients, our goal is 7%. So we will start with the oral diabetes meds. So there's a lot of different classes of medications, and they're usually somewhat based on how they work. So they can either help the pancreas either make more insulin or just release more insulin. We can also help the cells of the body, such as the muscle tissue, recognize insulin more or even just use it better. We can also decrease that production of glucose that comes out of the liver. And then we can also use drugs that kind of slow the breakdown of food throughout the GI tract and how quickly they are absorbed. So a few different things that we have, and we will mainly talk about the more common types of diabetes medications There's a few older ones that I have not included because they're not very often used anymore. But if there's something that you've heard of, or maybe you even take that we don't discuss and you want to chat about it, feel free to let me know. All right, so we are going to start off with an old one, but a good one. So metformin. This class was easier when we did it in person because I could always ask who's heard of metformin, and everyone would raise their hand, and everyone would have like a backstory about when they tried metformin. Metformin's a great drug. It is an older drug. I believe it was introduced in about the 60s, which in terms of drug lifespan is pretty old. And the reason that we love metformin so much is that we have lots and lots of data just showing that it works, it improves outcomes, it is relatively inexpensive. You used to be able to get it for free at Publix. They've stopped some of that. But I believe some Publix and some other pharmacies offer it for less than $10 a month. Metformin is generic now, but you might hear some of the old brand names, Glucophage or Glucophage XR. It's basically just the same thing, or it's immediate or extended release. So how does metformin work? It helps by decreasing that production of glucose or sugar that is released by the liver. So by doing that, we have less glucose within the body. It also helps the cells of the body recognize insulin better. We say it improves insulin resistance. And one of the cool things that metformin is that it is really good at decreasing A1C. So depending on what dose patients are on, we can get a reduction of A1C by up to about 2%. So one of our most effective medications at helping to control your A1C level. Metformin, how do you take? There's a few different dosing strategies. So a lot of patients prefer this XR or extended release metformin because you only have to take it once a day. Usually you can just take it at dinner. That way, if you have any side effects, things like that, you can just kind of sleep through it. But if you're taking the immediate release, usually once or twice a day, up to 3 times, but usually no more often than that. Side effects. This is another thing that if you've taken metformin, I feel like a lot of people know the struggle with metformin side effects. So unfortunately, the GI side effects associated with this drug are pretty common. So a lot of diarrhea, sometimes just some stomach upset. The good news is that these should go away. Usually, especially if you can continue past the first 2 to 3 weeks of taking the drug. But if it helps motivate you to stick with it, we also tell patients that it can also help with weight loss, usually about 5 kilograms, which is around like 10 to 12 pounds. And then it also can decrease cholesterol levels. So it can help decrease your bad cholesterol or your LDL while improving your good type of cholesterol or your HDL. There's even some really cool studies out there showing that metformin can help with reducing risk of breast cancer, other different kind of interesting data that exists out there with this drug. So like I said, we really love it. For type 2 diabetic patients, the guidelines recommend that everyone that has type 2 diabetes, if you can tolerate metformin, then you should be on it. And usually we tend to start with this medication and then add other things on top of it. So things to know, you may need to monitor both kidney and liver function. Nothing really outside of routine monitoring, but your physician will probably just get regular labs. We do avoid using this drug in patients that have pre-existing kidney disease, usually a little more advanced, just because it can accumulate. And then a big thing to know is that it also can interfere with contrast that you might get for a CT or a CAT scan. The physician should ask you, are you taking metformin? And if so, you can definitely get the scan. You usually just don't take the metformin for a day or two afterwards, but just make sure that the physician that is doing the scan is aware. So that's it for metformin. Next, we will move along to another class of drugs. These are another class of older medications. ones that aren't used a ton anymore, but you may still hear of them or even use them. So these are drugs called sulfonylureas. And the three that I put on the screen are the three most or more common agents. So we have glyburide, glipizide, and glimepiride. Pretty much all do the same exact thing, very similar in how they work and all what benefits they provide. But the way that these drugs work is they essentially help the pancreas to release more insulin. So basically, you have more insulin, and your body can handle the increased glucose more. They also make it easier for your body to respond to insulin. So they make those tissues of the body more responsive. And they also cut down on that release of sugar coming from your liver. Similar A1C lowering to metformin, anywhere from 1.5 up to 2%. So once again, pretty good for most patients. How to take. So remember, we're talking about 3 different drugs here. Usually depends on which specific one you are on, but anywhere from once to twice daily. And because they do help your body release more insulin, we tell patients to take them before they eat because you do have an increased risk of hypoglycemia. So these are good drugs if you eat consistently, if you eat the same 3 meals a day or at least one consistent meal a day. That way your blood sugar doesn't drop too low. The big side effect, like I just kind of alluded to, is therefore going to be hypoglycemia. So if you're someone that maybe tries to do intermittent fasting or you just don't eat reliably, maybe your work schedule is busy, things like that, probably not the best class of drugs for you. They are also associated with a little bit of weight gain, which tends to be the opposite of every other drug we're going to talk about. Usually nothing significant, but just something to be aware of. And then big thing to know, like I've already mentioned, is they can cause low blood sugar, which we're always trying to avoid. So if you are on one, make sure that you kind of are aware of signs of low blood sugar, and that you carry a source of sugar like glucose tablets or some hard candies or just like a Sprite or something with you if needed. Okay, so we are going to skip a few classes of older drugs that very few people are on, and we are going to move to one of our newer groups. So these are drugs called our DPP-4 inhibitors, and that stands for this big long word at the top of the screen. And these are basically drugs like Januvia, Onglyza, Tradjenta. They all work the same way and are very comparable to each other. So these probably came out about, I don't know, 10 or 15 years ago. And at the time that they came out, they were our newest class of diabetes drugs. So they were pretty exciting, but they work by helping the pancreas both make and release more insulin. They slow the release of glucose or sugar from the liver. And kind of a cool thing that they do is they slow how fast food travels throughout your GI tract and then how fast that food empties out of your stomach. So by doing that, you usually tend to have a more controlled release of glucose into the bloodstream after you eat. So that can help patients maybe eat a little bit less and then can also help them just have more sustained blood glucose levels after a meal or a snack. So unfortunately, they aren't as effective as the 2 drugs classes that we've talked about thus far. They decrease A1C by about 1%, but they are associated with a lot less side effects. They also are just taken once a day. They don't really need to be taken in relation to a meal because they work for a full 24 hours. But the big side effect is kind of these non-specific things. So some GI complaints, maybe a little bit of headache, but in general, not very common side effects. One of the big ones, if you look at the package insert that comes with your prescription, there's an increased risk of like nasopharyngitis, which is just kind of like a cold. Not really sure what that's about, but pretty safe drugs to use, and ones that we're seeing more and more because of how safe they are. Big thing to know, if you are on one of these medications, since they are new, they tend to be a little more expensive And that kind of goes for every drug I'm going to talk about the rest of the day. So anytime you see a drug that's new and there's probably a commercial on TV for it, I always encourage patients to go to the drug manufacturer website and just Google the name of the drug or just go straight to the website and pull up a coupon. So those coupons can usually be used in addition to insurance. So they will take whatever copay that you owe with your insurance down to $5 or $10 a month. Obviously they're completely optional, but unless you want to pay more every month, I would tell you guys to for sure do this. They're basically free money that the drug company is giving out for you to use their drugs. And then moving on, so this class of drugs, these are called SGLT2 inhibitors, and these are our newest class of diabetes medications. So these all came out probably about 5 or 6 years ago. The first few on the market were, I believe, Farxiga and Invokana. We also have Jardiance as well. And if you're into medications, I guess like I am, these are kind of exciting medications because we are using them for more and more things. The other cool thing is that they work in a completely different way than any other type of drug we're going to talk about today. So usually glucose gets out of your body by being kind of absorbed via insulin and brought into the tissues. These drugs actually help your body get rid of extra glucose by excreting it within the urine. So usually glucose is not excreted in the urine unless the serum level is around 180 to 200. And the way that these drugs work is they actually lower that threshold to a serum glucose of 150. So once your glucose level is consistently above 150, these SGLT2 inhibitors help to just get rid of that extra glucose in the urine. They decrease A1C by about 1 to 1.5%, so pretty decent A1C lowering. And they're also pretty easy to take, just 1 tablet by mouth in the morning. The other really interesting thing is we started with just an FDA-approved use of these drugs for patients with diabetes to help control glucose levels, but we actually now have a few more. So recently they gained FDA approval to help prevent the progression of kidney disease in patients that have diabetes. So we know that kidney disease is one of the major complications of diabetes, and these drugs are actually shown to prevent how fast patients progress to kidney disease. They also, very interestingly, have been shown to improve outcomes in patients with heart failure. And this is outside of whether or not those patients have diabetes. So this is 2 types of heart failure. We call it preserved and reduced ejection fraction. So it's basically all of our heart failure types. These are now approved for. So they improve outcomes, and then they also cut down on how often those patients are hospitalized. So if anyone here works with the cardiology group, I know those physicians are super excited about these drugs. It's kind of one of the big new topics in medicine, but super exciting for us and kind of interesting that these drugs treat all of these disease states. So side effects, they are unfortunately are not without side effects, but usually they are pretty tolerable for patients. They can lead to high potassium levels in the blood, usually nothing for you to be alarmed about, something that is often easy to pick up on routine labs. They are also shown to increase bad cholesterol, usually not significantly, but if you start one and you notice a little bump in your LDL, that could be the reason why. Because patients do tend to urinate more because they're getting rid of more glucose, there is the predisposition to have low blood pressure and potentially dizziness. So we do tell patients just make sure you're staying hydrated, especially if you're, living in Florida in the summer and we're all a little predisposed to dehydration anyways. And there is potentially an increased risk for urinary tract infections just due to increased glucose levels in the GU tract, and then also a slight risk of increased bladder cancer. which is really the main thing to know about these drugs, is that they do not recommend their use for patients that have a history or a family history of bladder cancer. The other big thing is that they are also still expensive, but just like the drugs we talked about with the DPP4 inhibitors, lots of drug coupons available, lots of strategies to get them to be more affordable for patients, which if anyone needs help with, is what I'm here for. So that is kind of it for the oral meds. So next we are going to talk about the injectable diabetes medications. This in the past was often just insulin, but there's actually a group of injectable drugs that are pretty common and I guess I would even say pretty popular now that we're seeing more and more use of. We won't really go into insulin, but I'll briefly touch a little bit on just like insulin basics for everyone. So the main class of injectable drugs that patients use for diabetes besides insulin are called these GLP-1 agonists. And these came out probably about 15, 20 years ago. The first one that we had on the market was Byetta. That was once a day. A few years later, they came out with Bydureon, which is the same drug, but you only had to use it once a week, which is pretty cool. Since then, we've had quite a few added to the market, Victoza, Trulicity, and by far the most common one now is Ozempic. If anyone here has heard of the drug Wegovy, Ozempic and Wegovy are the same medication. Wegovy is FDA approved for weight loss. It's a slightly lower dose than the Ozempic, but new within the past year and a half and very, very popular because it is one of the, if not the only effective weight loss drug that we really have available in the United States. But for our purposes today, we're just going to talk about Ozempic, which is only approved for diabetes. The other medication that you might hear about is called Rybelsus. This is basically an oral formulation of semaglutide. So it causes a lot of the same benefits. I guess main difference is of course you take it by mouth and you don't have to inject it, which some patients are a little weary of. But these are actually pretty painless injections. And even someone just said she got prescribed this. I will say people really love these medications. The needles are really small, but we see tons of use of it on the Gator Care side and just in general. So they're really kind of like taking off in terms of popularity. They do cause some side effects, which we'll chat about in a second, but for most patients, they just see such benefit that they're willing to stick with them. So yes, I love to hear like personal stories or questions. If you guys have them, throw them in the chat box. All right, so how do these drugs work? So these drugs work by helping your pancreas, once again, both produce more insulin and release more insulin. I know I'm sounding like a broken record saying the same stuff over and over, but the main benefit that they have, especially when it comes to their side effect of weight loss, is that they once again slow how fast all of that food and gastric contents are moving through your body. What this does is it slows how fast that glucose is absorbed into the bloodstream. So instead of that big spike of glucose that you get after you eat, you get a much more sustained release. The other thing that by slowing the stomach transit time is that you tend to feel fuller longer. So a lot of patients will say like, oh, I started taking Ozempic and I eat 2/3 of what I used to eat just because I'm not as hungry. And that's, for most patients a good thing, unless you feel like you're not eating enough. And of course, talk to your physician, but it just kind of helps people not overeat and it helps them stay fuller longer. A1C lowering depends on the product. Some of the older ones are not as effective, but honestly, we're not really seeing them used as much anymore. The big one, like I said, is Ozempic, super popular. But in general, you can expect about like a 1 to 1.5% reduction in A1C. But like I said, for most patients, the biggest, I guess, selling point of these drugs is that they do help with weight loss, which can also help with a lot of diabetes management as well. So how to take, these are all given via pen needle. I know a lot of people are very hesitant to inject themselves. Pen needles could not be smaller. They are teeny tiny little needles. If anyone's tried one and they want to like share with the group, you can barely even feel it. And where you inject it is, for lack of a better term, anywhere that you can grab. So anywhere that you have some subcutaneous tissue, it's usually pretty easy, like around your belly button. And you can kind of use your belly button as like a clock and just move from hour to hour. That way you don't kind of inject in the same spot and just will hurt a little bit. And even for patients that are a little nervous about sticking themselves, I always tell them just pinch your tummy, hold it next to your skin. And if you just exhale, you wind up kind of injecting yourself without realizing it. Very, very painless. And if you're someone that's not going to remember to take a medication every single day, some of these drugs that you can use once a week can be a great option to help with compliance. All should be stored in the fridge. They can be usually out of the fridge for, depending on what agent, you could leave them out of the fridge for the whole time once you open it. But just make sure that you're reading the package. You don't want to, pay for one of these drugs, take it home, and then realize you kept it in your hot car and then you can't use it anymore. But yeah, like I said, super common drugs that we're seeing more and more. Yes. So Sherry just shared with the group, she uses a teeny tiny Ozempic needle. Honestly, the needles are like, I don't think you understand how thin they are until you see one, but super painless. And I would not lie to you guys. So side effects, these are another group of medications that can cause side effects. Once again, these usually are something that patients tend to get used to. You just kind of have to stick with it. So usually about 2 to 3 weeks, you should start seeing yourself tolerate the drugs more. Maybe some upset stomach, lower GI side effects like diarrhea tend to not be as much as something like metformin. But a lot of patients will say totally worth putting up with it because of the risk of weight loss. So even positive things can be considered a side effect, which is why I put that little smiley face next to weight loss. There is a low risk of pancreatitis. We do tell patients this in the event that there may be someone that has had a history of pancreatitis, just so they're aware. And it's usually, this is still kind of not super well understood if it causes pancreatitis or if they just notice it more, but just something to keep on your radar, as well as a low risk of thyroid cancer. I believe this was still, unless there's new data out there, mainly seen in rats in studies, but any animal data we still report. So what do you need to know about these medications? Effective medications, good side effect profile that they help with weight loss. My two examples kind of have said like very well tolerated. You don't really feel the needles. Many patients can have problems with the side effects. That actually tends, I probably need to change my wording here. That tends to be like our older drugs like Bydureon and Byetta. Ozempic, and some of the newer ones are pretty well tolerated. And the other cool thing is that in addition to just lowering glucose and A1C levels, they actually have now, these drugs have now been proven to help with cardiovascular disease risk, mainly seen in patients that had a high risk. So it's still unknown, does this translate to everyone that has diabetes? But really we're looking at drugs now that have more than one benefit. So it's great if they lower A1C, but if they can also lower risk of things like cardiovascular disease, heart failure, stuff like that, that's even better. Get, more bang for your buck. And then once again, expensive. The Wegovy, like I said before, is only for weight loss. Ozempic is only for diabetes. You can sometimes encounter a few barriers, I guess, to coverage of these drugs, because insurances are just trying to make sure that patients are not using them inappropriately. But once again, same thing. If you're on one, unless you want to pay your full copay every month, get online, find a coupon, save $45, $50 a month. That way you don't have to spend as much on your medications. And then last but not least, we will talk about some good old-fashioned insulin. I am not going to go super into insulin. because this is a whole hour within itself, and I know you guys are busy. So insulin is essentially just replacing what should be happening in the body. So we usually give insulin by injection. Once again, subcutaneous. We have these tiny little needles now. There's also some inhaled insulin. Not super popular. If you've ever seen someone use it, it's a big inhaler. They have to use lots of puffs multiple times a day. So it didn't really take off like they thought it would. But in general, the insulin that we use via injection is categorized by how fast it works, but then also how long it sticks around in your body. So we have two types of insulin that we use before meals that kind of cover the amount of glucose that you will eat for that meal. We have rapid acting insulin and short acting insulin. And then our longer acting insulins that basically just cover that small amount of glucose that your liver is releasing every day. We have long acting and intermediate acting insulin for that. Our traditional old school concentration of insulin is called U100, meaning per every milliliter of insulin, you have 100 units. But if you guys see on TV, there's a lot of new ones now. There's a U200, U300. There's even a U500, but for most patients, they will be on just the U100. So this little, I guess, graph here on the right-hand side just kind of shows you basically in darker orange is the insulin that we have, as well as the glucose. So you can see at the top, we have insulin, and when your insulin spikes, and down at the bottom, you can see glucose. So basically what we're trying to do with an insulin regimen is to replicate this. So you would use a long-acting insulin to cover this basal amount of glucose that you have throughout the day, usually 1 or 2 injections a day. And then your mealtime insulin is going to cover all 3 of these spikes. So you can see for this patient, looks like they eat a little bit, maybe more at breakfast and dinner, and then less at lunch. So that's just basically how we design an insulin regimen, anywhere from, I guess, usually at least like 4 injections up to 5 to 6 a day. We won't really talk more about insulin than that, but I did want to touch on it. But if you guys have any insulin specific questions, feel free to reach out to me, like I said before. As we said, injected subcutaneously. So once again, anything you can grab. A cool thing with insulin is that we do have these old vials that have 10 mLs in each of them, but they also now have pens. So super easy to use pens. You just put one of those tiny little needles on it, you dial up your dose and inject it, and can also be helpful if you can't see super well because they click every time you turn the pen. So you can just listen to your clicks to figure out your dose. Side effects, I always hesitate to even call them side effects because insulin are things that we're just replacing that should be naturally happening in the body, tend to not have a ton of side effects. If anything, it might just be too high of a dose that could lead to hypoglycemia. Some patients say that they have a little bit of weight gain, but usually not more than a few pounds. So once again, any drug that you might be predisposed to hypoglycemia, we say carry sugar with you in some formulation. Glucose tabs are an easy one. If anyone's ever tried them, they are not tasty. Juice, whatever works for you. And then, of course, hypoglycemia is usually a glucose level of less than 70, but it's really whatever glucose level that you start to feel bad at, because some patients experience this a little bit higher, some patients might be lower. If anyone here has ever had hypoglycemia, you know, because you don't feel good. Dizzy, hot, heart palpitations, pretty sweaty, things like that can all be signs of hypoglycemia. So to treat this, we say the rule of 15. I'm sure John's gone over this with you guys. So 15 grams of carbohydrates. A big thing here is don't overdo it. This isn't a reason to eat, 95 Lifesavers candies. We say 8 to 10. You can eat a few glucose tabs, a half a thing of regular soda. Diet soda is not going to help you. Fruit juice, or if you're a milk drinker, if you want to have a cup of milk. And then the other part of your rule of 15 is that you check your blood glucose again in 15 minutes. And if you're someone that maybe this keeps happening to, you can also ask for a glucagon kit that your insurance covers, kind of just basically like an EpiPen kind of theory that you would carry with you if your glucose gets too low that you can't eat or drink something. A family member or a coworker or something could administer this to you. And then my final pharmacist spiel before I let you guys go for the day is, of course, don't forget these little pointers. So know all of your medications. We always ask when you guys go to your physician, try to bring an updated list to each appointment, especially if you're seeing multiple physicians in multiple different hospital um, systems or even in different offices. We also encourage you guys to try to use just one pharmacy or one chain of pharmacies. So pharmacies unfortunately don't speak to each other, but if you keep everything, for example, within like the Walgreens network, they can see whatever you fill at every Walgreens. Otherwise, we don't know about drug interactions, duplicates in therapy, things like that. And another question I often get is, what do I do if I miss a dose? First of all, don't beat yourself up. I am the worst patient in the world, despite being a pharmacist, and always forgot to take doses of medications. Big thing is don't double up on your dose. If you're confused, call your pharmacy just for some more clarification. But for most drugs, you just resume your dose, do it your next scheduled time. And then storage. So we put medications in those little orange bottles for a reason. It protects from light, it protects from humidity, moisture, things like that. So we encourage you guys to keep those in them or in a pill box that's securely closed. One crazy kind of thing is that I think everyone I know probably keeps their medications in the bathroom. Worst place to keep your meds, right? That is the warmest part of your house. Your shower's on, it is humid. It is a terrible place to keep medication. So we say in a cool, dry place. I personally keep everything in my kitchen in like my spice cabinet because it's dark and no one's going looking for anything exciting there. And then, of course, keep away from your kids as well as pets. We get lots of questions as pharmacists like, I'm not on this anymore. How do I dispose of it? Pharmacies actually, by law, cannot take your medication back. They can't even take it back to destroy it. So we say you can mix things with like coffee grounds. If you still use coffee grounds, you can mix it with cat litter if you have a cat. You can flush it down the toilet, which sounds crazy, but for a lot of like high risk medications, we say just flush it. If it's like a patch, you can of course just put it in a Ziploc bag and throw it out as well. But if you have questions about like specific disposal of a medication, let me know. JSO or a police station should also be able to take medications back and waste them as well. So if you want to drop all of yours off, they can deal with it. And that is all that I have for you guys. So like I said, here's my email if you guys have any questions. I can hang out for a minute or two if people want to throw something in the chat box. But other than that, thank you guys for your attention and for joining, and I hope you guys have a good day. We have one. Oh, thank you. Thank you guys too. All right, I think that's it. You guys have a good Wednesday.